Today we are going to talk about Guillain-Barré Syndrome or GBS. GBS is a collection of clinical syndromes which manifests as acute inflammatory polyradicular neuropathy with resulting weakness and diminished reflexes. GBS is a progressive disease with symmetrical muscle weakness, having absent or decreased tendon reflexes. Weakness can vary from mild difficulty with walking to nearly complete paralysis of all extremities, facial, respiratory, and bulbar muscles. Incidence 1 to 2 cases per 100,000 per year. All age groups are affected. Males are affected more than females, often provoked by preceding infection of respiratory symptom or GIT like Campylobacter jejuni. Gastroenteritis is the most common precipitant of GBS. AIDP and CIDP. Acute inflammatory demyelinating polyneuropathy or AIDP is an autoimmune disease that is characterized by progressive areflexia and weakness with mild sensory changes. AIDP is often referred as GBS. Chronic inflammatory demyelinating polyneuropathy or CIDP continues to progress or has relapses for more than 8 weeks. Clinical features. GBS is a progressive and symmetric muscle weakness disease with decreased or absent deep tendon reflexes, may also have sensory symptoms and dysautonomia. Symptoms typically progress over a period of 2 weeks. If nadir is reached within 24 hours or after 4 weeks of symptoms onset, alternative diagnosis should be considered. Progression over 4 to 8 weeks, sometimes called subacute inflammatory demyelinating polyneuropathy or SIDP. AIDP is the most common form of GBS. Common variants. GBS is a heterogeneous disorder with many variants: acute motor axonal neuropathy, acute motor and sensory axonal neuropathy. Miller-Fisher syndrome include ophthalmoplegia, ataxia, and areflexia. Bickerstaff brainstem encephalitis include encephalopathy with ophthalmoplegia and ataxia. Pathophysiology. Autoantibodies attack on peripheral myelin or axons. These antibodies generated in response to an infection that precedes the onset of neuropathy symptoms by days to weeks. These antibodies cross-react with myelin or exolemma antigens via molecular mimicry. Prodromal infections include cytomegalovirus or EBV. This concept is well established in axonal variants. Diagnostic criteria: progressive weakness of 2 or 4 limbs due to neuropathy with areflexia and disease progression less than 4 weeks. On CSF study, there will be albuminocytological dissociation. On electrophysiological study, there will be evidence of demyelination, usually without fever. Facial nerve or other clear nerves can be involved, and relatively symmetric weakness. On CSF study usually done after 1 week of symptoms onset. Albuminocytological dissociation at 1 week after symptoms onset will be noted. Normal WBCs in CSF, but if cells count is greater than 25 cells per microliter, then consider alternative diagnosis. Proteins are also elevated. There are 2 electrodiagnostic studies like electromyography and nerve connection studies or NCS. On NCS, F waves and H reflexes will be noted in GBS patients. Other labs. In Miller-Fisher syndrome, GQ1B antibody will be positive, and spinal MRI thickening and enhancement of intrathecal spinal nerve roots and cauda equina will be noted. Treatment. Follow respiratory function closely. Immunomodulatory therapy such as plasmapheresis or IVIG 400 mg per kg per day for 5 days. Plasmapheresis for removal of large molecular weight substances like autoantibodies, immune complexes, and cytotoxic constituents from plasma. Glucocorticoids not recommended. Pain relief can be achieved by NSAIDs or acetaminophen, and gabapentin can be added for neuropathic pain.